Welcome to this podcast, which is going to present some current hot developments in spinal cord injury. I'm Michael Fehlings. I'm professor of neurosurgery at the University of Toronto, and I'm the lead of section development at the North American Spine Society. And I'm joined by several prominent individuals in the field of academic spine surgery and specifically spinal cord injury. Dr. Yi Liu from the Mass General Brigham, Harvard, Dr. Rajiv Saigal from the University of California at San Francisco, Dr. Brian Kwon at the University of British Columbia and the I-Cord Spinal Cord Injury Center. We'll lead off with Dr. Liu, who's also the co-lead of the spinal cord injury section of NASS.
Thanks, Dr. Fehlings. So I would like to summarize, and we have an excellent symposium on the spinal cord injury state-of-art advancement. And Rajiv and I had chaired the symposium, and excellent advance in technologies. We talked about nerve transfer with Dr. Zach Ray from the nerve transfer helping the up limb advancement with the spinal cord injury patients. We talked about brain-machine interface with Dr. Ian Cahigas, and also the focus of today's symposium is on the spinal cord stimulator. Excellent data was presented. Dr. Uzma from Minnesota presented her experience with 64 patients who had implanted spinal cord stimulator. The results are really amazing, and I encourage everybody to get to listen to that and know about the study.
Thank you very much, Dr. Saigal.
Sure. First, I'll just build on that. I enjoyed participating in the same session, and another topic. Some of those new techniques are surgical, including implanted epidural stimulators, but there's also, of course, the topic of non-invasive or transcutaneous stimulation. And another thing we talked about in the session was the recently published UPLIFT trial, which came out this spring and showed some benefit for regaining upper extremity function using non-invasive or transcutaneous stimulation centered over the cervical spinal cord. And this was the first prospective study showing that. These are all chronic spinal cord injured patients. And I think that is an exciting development. We have often focused on lower extremity function in walking for our patients, especially for outcomes. And the upper extremity function is very important to the patient. So I think that's one thing to look out for. And we don't know whether non-invasive or epidural stimulation will become the more prevalent, and probably there'll be a segmentation where some patients benefit from one, some benefit from the other, but these are all emerging areas to look out for.
Terrific. And Dr. Kwon.
Well, I think one of the things that we've had a very shared interest in is in the hemodynamic management of the acutely injured patient with spinal cord injury, and I think it's a common interest because it's one of the few things that we can do for patients with an acute injury. As part of an initiative that Dr. Fehlings and I led through the AO Spine and Praxis Spinal Cord Injury Institute was a new guideline on the hemodynamic management of acute spinal cord injury. And this really it wasn't necessarily a continuation of the AANS CNS guidelines that had been published in 2013. But we certainly acknowledge that over the last decade, there's been a lot of work that's been published in this field. And we felt that it was a good time to summarize that literature and really put forward a recommendation around the early management of the hemodynamics in patients with acute spinal cord injury. What emerged from that and what was published this year is a guideline in which we really summarized all that we could find in the literature on this topic. And we arrived at a guideline that recognized that there are limitations in the literature on this topic. But when we really kind of summarized that and subjected it to a very rigorous grade methodology and framework, that the guidelines committee came to the recommendation that of a MAP target between 75 and 80 at the low end to 90 to 95 at the high end for a period of 3 to 7 days. And this kind of acknowledged the fact that if you really scrutinize literature, there isn't super strong evidence for an exact MAP target as a way of promoting neurological recovery. And so this guideline, I think, provides really a perspective on what is sort of best gleaned from the literature as a low end for the MAP target and a high end for the MAP target, and provides a little bit of more leeway for the duration of the management, somewhere between 3 and 7 days. So that was published this year as part of our guidelines initiative, and we certainly are very interested to see this get disseminated and see how people utilize this in their practices.
Thank you, Brian. From my perspective, I'll perhaps summarize some emerging knowledge that was actually shared at the North American Spine Society. And perhaps I'll begin with another topic in the recent AO Spine Praxis Institute guidelines for spinal cord injury that Brian alluded to. So one of the topics that we tackled was an update on the role and timing of surgical intervention for spinal cord injury. And since the 2017 guidelines that had largely relied on the STASCUS study, there were a total of 21 studies that allowed us to do a more quantitative assessment of the literature with meta-analyses. And from that emerged a strong recommendation that when medically feasible, surgical intervention for acute spinal cord injury should be undertaken within 24 hours. Now, from this practice recommendation, it was acknowledged that there are many important knowledge gaps that exist. And the medically feasible caveat's an important one because it's recognized that we have an aging population with patients that may be medically frail, and it may not always be appropriate or feasible to take these patients to the operating room on an expedited basis, and that's entirely appropriate. It's also recognized that mild central cord injury is becoming one of the most common, if not the commonest form of spinal cord injury that we're seeing in high-income countries. And this is really a different issue that's not actually addressed by the guidelines. And I'll make reference to a current study that's underway through AO Spine called the INTWIN study that's being co-led by Dr. Kwon and Dr. Jefferson Wilson out of Toronto. And this is seeking to examine the whole issue of mild central cord injury. And furthermore, it's recognized that there are logistical challenges in terms of implementing this time as spine concept. So there can be transportation issues and there may be infrastructural issues related to the availability of skilled personnel to be able to undertake a surgery. And so this is an example of where we have a guideline, but there needs to be a continued effort toward the knowledge implementation. And then just in a nutshell, some other emerging topics. At this NAS meeting, I presented on a reanalysis of the RISCUS randomized controlled trial, which examined the potential efficacy of riluzole, a sodium glutamate antagonist, in acute spinal cord injury. The reanalysis used a novel statistical test which looked at the multidimensional nature of spinal cord injury assessment. And essentially, we combined the total motor scores with a measure of function, the spinal cord independence measure, and a measure of global health-related quality of life, the SF-36. And using this approach, we actually saw a positive signal for riluzole in acute spinal cord injury. And we might suggest that this could be an attractive option that clinicians may wish to consider. And in the next year, we're going to be seeing the results from some interesting phase 1 and phase 2 studies, which are examining approaches to target various inhibitory molecules, including NOGO. This is the NISCI trial being done by the European consortium led by Armin Ockert, and there are two separate phase 1 trials by AbbVie and Mitsubishi Pharmaceuticals looking at methods to target repulsive guidance molecule A or RGMA as a potential therapy. So there's going to be a lot of activity occurring in the next year. So I might ask each of our panelists, perhaps in closing, to give us a thought on, what you see as perhaps some interesting developments that might be occurring, let's say, on the near timeline horizon.
The near timeline horizon, I would say what part caught my eye the most is the spinal cord stimulator, and I think that's in the field that's really has the potential to changing the field of how spinal cord injury patients being treated. And long-term wise, I'm doing a lot of studies in studying. I think there's a lot of science advancing in understanding the intrinsic pathways, how to make those pathways better, and how to decrease the immune response within the spinal cord after spinal cord injury. But that's certainly in the long term.
Rajiv?
So I agree with you that spinal cord stimulation, neuromodulation is exciting, but I'd add the caveat that even when we see some improvement in published studies using neuromodulation, it's still not a cure, and those patients still don't move normally, they don't walk normally, even if they are able to regain that. And I think many of us in the field feel that some combination of therapies is really what's going to ultimately help our patients. I'll just mention one other trial that was published this year that I think is a different and exciting approach was the CellTop trial that came out of Mayo Clinic. Mo Biden is the first author. And they used mesenchymal stem cells, adipose-derived mesenchymal stem cells, where they harvested some fat from the same patient, processed it, then injected it intrathecally. And there's a phase 1 safety trial. They injected intrathecally, but in the phase 1 trial, they did find it to be safe, and there was maybe some modest improvement in 7 of those 10 patients that they enrolled. So I think some sort of regenerative therapy like that maybe can maximize the number of cells that are available for enhancing rehabilitation could be exciting down the line.
Very good. And Brian?
Well, I think that, picking up maybe on the theme of neuromodulation, I think one of the things that we're aware of in the field is that for patients with spinal cord injury, there is a lot more to their disability than walking or movement. And I think one of the really exciting things that's coming down the pipe is around the use of neuromodulation for blood pressure control. And this is work that I think has being driven out of, a number of centers, but Switzerland in particular, where targeted electrical stimulation of certain aspects of the spinal cord may actually help people in the control of their blood pressure. And this is actually, I think, a huge issue. It's not hand function, it's not walking, but orthostatic hypotension can be severely disabling for patients with chronic spinal cord injuries, and this approach may actually be extremely helpful for them. And I think we're going to see some very exciting things coming out in the near future on this.
A lot of exciting developments occurring in the field of spinal cord injury. And I think kind of in closing, one of the areas that I think is going to be fundamentally important is to really develop a personalized approach to understanding the heterogeneity of patients with spinal cord injury and becoming more fluid with regard to understanding the different trajectories of outcome. We recognize the intrinsic limitations of only using the ASIA score. We're getting a greater understanding of this. And then also potentially the way we assess patient outcomes. So clinical trial design, the use of machine learning and AI algorithms to more accurately predict outcomes. So in summary, this is our NAS podcast on new and exciting developments in spinal cord injury. And we look forward to updating you at next year's NAS meeting.